Today we are here to discuss about the basics of electrocardiography. The ECG is very important for the cardiology because in spite of we have been increasing our diagnostic techniques so much and so sophisticated technology has been available right now, but the first and foremost technology wherever we go and whatever we do, the first thing we do always is electrocardiography, that is ECG. So here we are just talking about the basics, how the generation, how to interpret, how to evaluate, and especially our day-to-day common problem like myocardial ischemia and all these things we are going to talk here. So not wasting too much time, I request Dr. Rajnish Sardana to take this session.
Dextrocardia and how will the ECG look like? I think it's a very complex issue, but just to summarize here, if you're talking about situs inversus dextrocardia, then the whole activation is going to be different. So your P wave is also going to come instead of this RA has gone to the left and the left has come to the right. So your depolarization wavefront will be now in this direction. So the right side will record a positive P wave, that means AVR, and V1 will be a positive thing. And if you look at the ventricle complexes, the heart is now situated to in this direction. So depolarization, the whole thing is reverse. So what you will see is when you're recording on the lateral side is that there's a gradual diminution of the voltages as you go from V1 to V6. On the other hand, if you start recording ECG on the right side leads, there will be a gradual increase in the voltages and it will mimic the same ECG as in a normal heart if you record from V1 to V6. So that means our V1 to V6 will be similar to the normal V1 to V6 of a normal heart. That's in brief. Intervals, I think I could have gone into it, but we'll have to skip a lot of things if we get into that. The normal P is 0.12 seconds, the PR interval is 120 milliseconds to 200 milliseconds. I think these things are very well known to most of the people and they are available, and it doesn't require understanding, it requires memorizing. So it's not going to be a big thing trying to talk about that. My idea was to make you understand so that you can apply it rather than mug it. So evaluation of an ECG here, when an ECG is given to you, people start talking about acute MI. So you have to learn a way on how to talk about it. So the first thing you talk about is the rhythm, which is it a normal sinus rhythm, then we talk about the heart, then the rate, then we talk about the axis, then we talk about the chamber hypertrophy, then we talk about the STT changes. So in an examination point of view, you have to follow this pattern unless somebody tells you give me the diagnosis. Okay, so if you don't do this, you're going to lose marks here. So the first thing we talk about is the rhythm. As I told you, you should look at the morphology of the P wave first and say, okay, it's coming from the normal side. So you've got a normal looking P wave, so you call it normal sinus rhythm. The heart rate has to be between 60 and 100 for a normal rhythm. Anything below 60 is bradycardia. You said normal rhythm, sinus bradycardia. More than 100 you call normal rhythm, sinus tachycardia, whatever. So the rhythm is a normal NSR, regular or irregular you have to see. Regular rhythm is if the difference between the longest RR and the shortest RR is less than 120. Mind you, there is a little variation between RR intervals in the ECG when it is a regular rhythm, but that variation should be less than 120 milliseconds. When the variations is more than that, they are called irregular. As I said that we are not going to handle the arrhythmias here, and probably will get a chance at some later time to talk about arrhythmia. It itself is a complete topic. So right now all I wanted to put in a slide was a regular rhythm as shown here. We've got a QRS is coming at a regular interval, or we've got an irregular rhythm like in the bottom here and also in the top frame here. So that's an irregular rhythm, but this is a more obvious, the lower one being atrial fibrillation. The rate is the next thing when we talk about. Remember, when you see an ECG, always look at the paper speed, which is normally 25 millimeter per second. You can get taken in if the speed has been fast or slow, and you can make wrong diagnosis. On a paper, if you see this, the ECG paper looks like this. 25 millimeter is 5 boxes is equal to 1 second. So in the enlarged view, we've got the smallest square is 40 milliseconds on the x-axis, and on the y-axis we have the voltage. So 5 small squares will make 0.2 seconds and 5 of these squares will make 1 second. Okay, so this is the time frame which you have to understand, and then we go ahead and record the heart rate. So for simplicity, we follow these pattern. If you've got a QRS to measure, look at the R wave and look at the next. If the gap between the two QRSs is one big square, the heart rate is 300. If the gap is about 2 squares, it is 150. So you divide 300 by the number of large squares between the QRS complexes in a regular rhythm. So if you got 3, we got 100, if you got 4, we got 75, and so on and so forth. But if you've got say 2.5, so now don't get confused here, so you are between 100 and 150. Okay, so depending, it is somewhere mid between, then it's 125, but it is closer to 3 squares, then it is just over 100. So it's a rough estimation, it's not an accurate. For accurate calculation, there are ways as well. As we see in this rhythm here, we look at the QRS and we look at the big squares now. So if you calculate 1, 2, 3, 4 and 5 squares, so what would be the heart rate here? It will be 300 divided by 5 squares, so it's a 60. There are other ways to do it. As I have shown here, we have number of QRSs in 6 seconds. On the ECG graphs, the traditional ones, at the end of every 3 seconds, we have this line going onto the white border. If you can see it here, we have this going across, and 1, 2 and 3 will have another line here, then 1, 2 and 3 we have another line here. So every 3 seconds we'll have the line on top of it which is extended. So it's not a misprint. Okay, so this is 3 seconds. If you calculate this and this, so you count the number of QRSs between say 6 seconds. So if you calculate here, so 1, 2, 3, 4, 5 and 6 here. Okay, so 6 is in 6 seconds, in 60 seconds it will be 60. Okay, so simple. But if you had measured it in 3, so you would have to multiply it by 20. So 1, 2 and 3 here in 3 seconds, multiplied by 20, again it comes to 60. The third way, the most accurate way would be 1500 divided by the number of small squares. Okay, so if you look at these, the number of small squares between, look at these two complexes is 5, 10, 15, 20, 25. So it will be 1500 divided by the number of small squares, 25 in this case. So it again comes to 60. The fourth way is looking at the RR interval. In 5 boxes, so one box is 200 milliseconds, 40 milliseconds, 5 squares, small squares, 200 milliseconds, 5 big squares is 1000 milliseconds. So 60,000, which is the 60 seconds, divided by 1000 milliseconds, so which is again 60. I would probably advise you to go for the third one if you want a reasonably accurate heart rate, 1500 divided by the number of smaller squares, because they never are going to be too many or too little. So it's going to be probably 3 squares or 4 squares or 13 squares or 14 squares, and then you have to calculate. Okay, so this is the most reasonable way of finding the heart rate. So for you to go through this, we have this again the same ECG. We calculate the heart rate. If the QRSs were here, it would be starting from here 300. It was here, it was 150. So it is on the fifth one, it is 60. The next thing is the axis, where most of the people get foxed. What is an axis? Okay, axis is the direction of the resultant of heart's electrical forces in relation to the frontal plane of the body. Normally the heart is situated on the left, and we've just learned that the SA node, from there it activates down to the AV node, and from the AV node the forces are acting towards down and little bit on the left. These forces get altered if there is an anomalous heart, like if you have a dextrocardia, somebody is saying, if you've got myocardial infarctions, if you've got diseased heart, chamber hypertrophies, these axis conduction blocks gets altered, and they have their own diagnostic value. So if you look at the heart as shown in this diagram again, now you've got a heart in the center, and the normal forces are down and to the left, and the normal axis is between -30 to 120 degree. So this is for you to memorize. The normal axis is from -30 to 120, and this is the cross section for you to see if the heart is lying in the chest. So this is 120 direction, this is about this is 0, this will be -30. So your normal axis should stay within this. Normally it will be around 60, 75, 90, as you can see very well, but depending, the heart can be little horizontal, it can be little vertical. Normal variation, thin built people can have a little horizontal heart in a COPD, or if the diaphragms are pushed up in an obese person, it could be a little horizontal heart instead of vertical. So the axis can vary a little bit, but it will be within -30 to 120. This is coming back to that triangle of Einthoven I talked about. If you look at, we have the RA and the LA, the lead 1, the lead 2, lead 3, and we have the AVR, AVL and AVF. All we have to do is change this diagram into a diagram like this. How? By transposing the lead 1, lead 2 and lead 3 to go through a common point, the center of it. So all we have done is we've taken the lead 1 from here and pulled it down to this point. We've taken the lead 2 from here and parallelly moved it down. So we've got lead 2 here. So we've got lead 1, we've got lead 2 and lead 3 here. And AVR, AVL and AVF are already there. So we've got a hexaaxial system now. If you just memorize, the 0 on this is lead 1. The 90 on this is lead AVF. It simplifies things for you. Okay. So now when you have to calculate the axis, we look at lead 1 and AVF to simplify things. So if your complex in lead 1 is positive, so draw a line on lead 1. So if it is say 5 or 10 millimeter, so you draw a 10 millimeter line here. Supposing this is 10. Now you look at lead AVF. If it is positive, say 6 millimeter, so you go to 6 millimeter down here. You complete the rectangle here. The diagonal tells you the axis of the heart. Okay, so this is going to be accurate. If you put a protractor there and measure the angle, that's I think how we used to do it in geometry. So you'll get a accurate angle. But if you want to just have a guess at it, you know this is 0, this is 30, so you are somewhere around 27-26 degree. Why we use rectangular? Because the trigonometry does not come into play. You can always do this and then draw a parallelogram and get a diagonal of that, and then you'll have the cos thetas and things like that coming into play. I think this comes into as tan theta or something like that, which comes as 1. So all you do here is always, so if you've got lead 1 which is positive in short and lead 2 as positive, this is one way to do it, where we do this. If you have lead AVF as negative, it will come here. If you have lead 1 as negative and AVF as positive, it will probably come somewhere here. This is how we are doing it. Remember lead 1 and AVF to calculate the axis. This is the same way of defining the whole thing, is now put it in a neat way. So we got lead 1 representing the 0, on the negative side minus 80. This is AVR at the 30 to minus 50. This is lead 2. So we've got alternating leads between standard leads and augmented. So AVR, this is lead 2, this is AVF, this is 3, this is lead AVL. Normal axis, as I said, normal axis between minus 30 and 120. All it means is that in normal ECG, the complexes in lead 1 and AVF are both positive. That's the crux of it. So this is also positive, this is also positive, it will come in this quadrant. In a lead, so this is the synopsis of the axis. If lead 1 is positive and AVF is positive, the axis is normal. If lead 1 is positive and AVF is negative, the axis is leftward. For you to just go back again, lead 1 is positive and AVF is negative. So you are going to be in this quadrant, correct? So we've got a left axis. If your lead 1 is negative and AVF is positive, that is as seen here, it is negative and this is positive, you've got a right axis. So if your lead 1 is negative and AVF is positive, you've got a right axis deviation. If you've got this also negative and this also negative, it is called indeterminate or northwest axis. Like in ventricular tachycardias, we say he has there's a northwest axis which goes in favor of that, right? So 1 and AVF are something which you look at. Even if you don't know more than that, you will be able to calculate the axis of the ECG. So this is an example of the left axis where you've got 2, 3 AVF as negative. So you got an RS complex in a left axis situation. The causes are, it can be a normal variant, left anterior fascicular block, left ventricular hypertrophy, inferior wall MI, some variety of WPW. Right axis, already described, lead 1 would be negative in this case, AVF would be normal. Again, normal variant, left posterior fascicular blocks. Okay. So right axis is left posterior, left axis was left anterior hemiblock. Right ventricular hypertrophy in children, it can be a normal. Right axis deviation is normal till a certain age. Lateral MI and some WPWs. Coming to the next step, which is the atrial hypertrophy. So left atrium, you will have a broad and a notched P wave which is greater than 0.12 seconds or 3 small squares. There is a large terminal negative P wave seen in V1. The negative part of it has to be broader than 1 square. So 0.04 seconds. So the P wave goes down and is broad. I'll show you that, which is described as a P mitral. So these are the two criteria which you try and remember. The broad notched P wave is left atrial enlargement. Right atrial enlargement is tall P wave which is more than 2.5 millimeter in height, but the width is not broad. Biatrial, you will have a P pulmonale or a tall P in lead 2 and a bifid or a negative P terminal in lead V1. So as you see here, left atrial enlargement, we can see a broad P wave here with 2. Why are there 2 notches here? Because the first one is the atrial depolarization on the right, and the second one, because the left atrium is large, it takes much longer. So the second notch after that is the depolarization of the left atrium. As you see here in this one, you will have a notched P wave, and this is the V1 enlarged for you. So you will have a negative component here which is at least 1 square broad. Okay, this represents a left atrial enlargement. Right atrial enlargement is not broad but is tall peak more than 2.5 millimeter in height. So this is a classical P pulmonale or a evidence of right atrial hypertrophy enlargement, and this is left atrial enlargement. Coming to the ventricular hypertrophy, in brief you try and remember 1 and 2 for practice, and for exams you try and remember more criteria. ST's criteria is the most complex point system but supposed to be with best sensitivity and specificity. R wave in V5 and V6, because of the ventricular hypertrophy the LV mass is more, so you will have larger complexes on the lateral leads. LV stands on the left side, so you will have larger complexes. So you will have a R in V5, V6 or a negative in V1. So you will have a deep S in the V1, V2 leads and positive big ones in the lateral leads. So R in V5, V6 or plus S in lead V1 greater than 35 millimeter, or just R in V5, V6 greater than 27 millimeter. Similarly, R in AVLS greater than 11 millimeter. So this is an ECG showing LVH. If you see here V1, V2, you see a complex which is about 25, 27 millimeter, and on the V5, V6 we have something about 30 millimeters. So the total is about 50, 55. Okay. Usually LVH will again be associated with STT changes. The STT here, you will have a asymmetric STT here. So you will have reciprocal changes of showing an ST depression and T inversion, but they are not symmetric T's here. Okay. So these are changes which you will see. Right ventricular hypertrophy, I think all you try and remember is the first and the third criteria. R by S ratio greater than 1 in V1. And as I told you initially, R in V1 is never normal. So you should have a normal complex as what? A small r and a deep S in V1. So if you have just a positive R wave in lead 1, it is abnormal, and the commonest cause would be a right ventricular hypertrophy. Like in pulmonary stenosis, you will get a tall R wave in lead V1. If it is more than 7 millimeter, that's also a criteria given. Combination of big R in V1 and a big S in V5, V6 more than 10.5. These are criteria which are available everywhere, but you will have to in practice try and memorize, and then you dig out more criteria on that. Right ventricular hypertrophy as seen here, classically if you look at lead V1, you have a very tall R wave in this. Okay. So this is not normal complex. Remember the normal ECG, it was a little like this was the complex. So little up and rest was negative, so RS. But here it is a positive, so this is PS, pulmonary stenosis. Ischemia and MI is through and through. I think we have to focus on the ST segment and the T segment here. We've got 3 types of damages to the heart. So we've got ischemia, we've got injury, and we've got an infarct. Infarct is a dead muscle. Okay, the muscle has got necrosed, so that is represented by a Q wave. Ischemia is represented by the ST segment depression and T wave changes. And injury, like in MI, myocardial infarction, before the infarct sets in, is shown by ST segment elevation by and large. Okay, so elevation, ST elevation stands for injury, ST depression, T wave changes, ischemia, and Q wave for infarction. Localization of myocardial infarction, again similar to what we had talked earlier. Inferior infarction is 2-3 AVF, anteroseptal infarction is V1 V4, V1 to V4, lateral will be 1 AVL V5 V6, right side infarct would mean in lead 1 or right sided lead 3 and 4. Posterior infarction is seen as a tall R wave in V1 because it is not represented in any of the ECGs. So it is shown as a negative in V1, so you have a tall R wave. So one of the causes of tall R wave besides RVH would be a posterior infarction. This is a classical what you call as an hyperacute MI. So you've got an ST elevation in the 2, 3 and AVF. So it's an inferior wall MI here. The issue here is the convexity. In MI, concavity has to be downwards and the convexity is upwards. Okay, so in other words, if I draw it for you, the elevation will be like this. Okay, so you got like this. Whereas for a pericarditis, it may not be convex like that, so it is like this. So it's going from, that's the difference between convexity. Okay, so this is curving like this MI, whereas that it is curving like this. So this is a inferior and lateral MI. This is a ST elevation MI, the terminology used now, STEMI in the anterior leads, V1, V2, V3 and V4. Here the Q wave is already formed. That was an hyperacute stage. This is an acute or a anterior wall MI of some duration. We still have ST elevation, so it's an evolving anterior wall MI. Remember the early depolarization. This is usually seen in young people where you will have an early takeoff in the ECG and it will mimic or create a doubt of an MI. Okay, so it's important to keep these ECGs, tell them to do a serial ECG to clarify whether it's an MI or not. In acute pericarditis, the concave upward ST elevation is seen in most of the leads rather than in one territory. There are no reciprocal ST segment depression. Unlike early repolarization, T waves are usually low amplitude and may see a PR segment depression. These are the differences between ST elevation of acute pericarditis vis-a-vis the myocardial infarction. So ST reciprocal STT changes are not seen. The ST elevation is concave upwards. Coming to the ST depression now, the ST depression indicates ischemia. What I wanted to tell you here, the ECG you can see the ST depression in 2, 3, AVF, but the most important thing here is this. There can be 3 kinds of ST depression. This is a downsloping ST depression, this is an upsloping ST depression, this is a flat ST depression. So upsloping can be a very common thing, it can be a normal variation. At very fast heart rates, you see this very commonly in treadmills which were being reported as positive. This is an upsloping. The significance comes for a flat ST depression or a downsloping ST depression. So you will see this treadmill reports which says 2 mm downsloping ST depression. The significance is much more than the upsloping. That's what I want to tell you. Q wave MIs this is in lead V1, V2, V3 you see there is a Q wave. So evolution of MI, there is an ST elevation to begin with, the ST starts settling in, you have the Q wave start forming, and I think we have an ECG on that. As you see here, we have the acute, hyperacute, the same ECG, but this is after it settles down. So the ST starts coming down, the Q wave forms and the T starts inverting. So finally you are left with the Q wave and probably an inverted T wave. So this is a regular evolution of an MI. The Q waves, we were talking about pathological Q waves. You can have a normal Q wave as I told you right from the beginning in the lateral leads. 1 AVL, V3, V5 and V6. Lead 3 also you will see a lot of patients will have a Q wave. You ask them to do an ECG with a deep inspiration, it disappears. Okay, but if you see it in 2, 3 AVF and it is pathological if it is more than 1 small square in duration, more than 0.04 seconds and the amplitude is greater than 25% of the accompanying R waves. These are the 2 criteria which are mentioned for pathological. A broad deep Q wave is a pathological and has to be into a particular territory. Okay, so just on lead 3 is not good enough, but if you see it in 2, 3 AVF, that's probably indicating an old infarction in the inferior territory. Bundle branch block, what happens is your activation pattern, instead of coming down and activating both ventricles, like here the left is blocked here, so it comes down the right, activates the right side first, and then it goes to the left from the right side. So that initial, the whole depolarization sequence is changed, so you don't have that initial left to right septal depolarization. So you'll have, the criteria are that the QRS duration is broad now because the latter part is depolarized from muscle to muscle. So it will become broad here. It will take more time, more than 120 milliseconds. There is an RS-R dash pattern. Okay, so there is an initial depolarization wave, which is again from here the septum, muscle, and the final depolarization wave. So you'll have two RS-R and the second R dash. So you'll have a M pattern in lateral leads, which is 1 AVL, V5, V6. We have wide slurred S in V1, V2. We'll have reciprocal STT changes in lead 1, AVL, V5 and V6. There's something called a late intrinsicoid activity, which all it means is R peak time, which would mean the time from the beginning to the peak of QRS. So in LBB we look at the lead lateral leads, V5, V6, from beginning to how much time it takes to reach the peak of the R wave. So in LBB it's going to take more than 60 milliseconds or 0.06 seconds, and there will be important, there will be no Q wave in V1, V2, sorry, there will be no Q wave in lead V5, V6, not V1, V2, right, because there is no septal day. Coming to the right bundle branch block, now the whole thing is changed, the pattern. So instead of the block here, we've got a block here. So the initial depolarization takes place like this and then down towards this. So what we will have now will be a M pattern in lead V1, V2. So you have an RS-R dash pattern in lead V1, V2. The QRS will again be broad. There will be a slurred S in V5, V6. There will be an STT depression changes in lead V1, V2. The late intrinsicoid onset in lead on the right side, V1, V2, not right side leads, but right side chest leads, you can say V1, V2, which is more than 0.04 seconds. And there will be a normal initial septal depolarization. It does not affect the initial left to right depolarization, the right bundle branch block. So you'll have a small Q in the lateral leads in this case. So in other words, in MI also, in presence of RBB, it does not mask the MI, whereas left bundle branch block will mask an MI. So if in RBB if you got Q waves in lead V1, V2, it also indicates an anterior wall MI alongside. If you have Q waves in lead V5, V6, indicates a lateral MI.
I think Dr. Sardana has done very good and important job, and he conclude this very difficult topic in a very fine way, and I think all of you must be benefited by his words of wisdom. Thank you very much.